Hi, my name's Randall, and this is my reflective practice for the ultrasound guided PIVC insertion, which unfortunately I've not been able to complete successfully on a patient to this stage. So as a description for the situation that we're in, after undertaking the theoretical modules of this course and after the practical day was spent with Evan, I was very much looking forward to putting these skills into practice, but I did discover that there's actually a couple of barriers to this in my particular situation. What became very clear early in the day with Evan on that practical day was the time required to successfully and most importantly for patients comfortably insert the PIVC is there's a lack of time. There have been opportunities where patients I've cannulated could have had an ultrasound guided PIVC, but just time and pace of private theatre lists has not allowed the opportunity to do so. And just as a background to that again, if I deem a vein too hard or deep and report that to the anaesthetist, they immediately just say, don't worry about it. And either through the case or after the current case, they go and insert that cannula. And writing into that as well is the anaesthetist's preference of that cannula placement. So in theatre, the placement of that cannula is dictated by where the anaesthetist wants it, and it is always for ease of access for that unconscious patient on the table. So, 99.9% of times for us, it's always in the hand that's most easily accessible, and very, 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 very rarely in those deeper tissues. So further to that, just to discuss that, my initial feelings on that of excitement, I guess, to pop those new skills into practice. That excitement was pretty soon tempered. Personally, I don't have any qualms about popping or using new skills, learning new skills, and then making that part of my practice. Because ultimately I want the best outcomes for my patients in terms of pain management and certainly to reduce the anxiety, because being an anaesthetic nurse, the number of times patients verbalise that anxiety is quite staggering. Like it happens on a very regular basis. So previously I highlighted that I work in a private theatre setting, and that really emphasises, I guess, my frustration in not being able to put these skills into practice, because I do believe, after my education through those modules and also the practical day, it would benefit patients no end. It would just make such a difference. And then the situation just really underscores that while we promote a learning environment in that private setting, it's very much dictated by time pressures, which are ultimately detrimental to learning skills that use more time. I guess it's one of the paradoxes that we have to live with. And coming from a public hospital system, frustratingly, it is something I see daily. So to evaluate that, I guess I feel that the time barrier that we face is detrimental on several fronts. Firstly, just the fact that it's more humanistic at times to accept that you have to take time to reduce patients' anxiety over having those cannulas inserted and the discomfort they potentially cause some individuals. There's also the added potential of complications such as infection, becoming displaced, pain, damage to the smaller or the more delicate layers of the veins themselves, let alone just the pain itself. It's all anxiety causing. So that ultimately speaks to the psychological effect of multiple attempts of insertion and what it has on the patient. And as I alluded to before, I can't tell you how many patients I've had actually say, look, you're going to take multiple attempts to do this. Whether I do or not, mostly I don't, but it certainly speaks to the anxiety that they feel when they're facing a cannula. So to analyse that a little, for me there's really no lack of opportunity or lack of DIVA patients. Just the sheer number of patients that come through presenting themselves would maintain a very high level of skill level. The benefits for patients that require this procedure are both physical and mental. So up to 67% of first insertion attempts are unsuccessful, so a new PIVC paradigm should at least be considered. The associated impact on affected patients and the burden to the health system in resource management and cost is significant. And further to that, typical research to date, DIVA patients report that they see significant reductions in pain, anxiety. They've also got improved success rates when going ahead with the ultrasound-guided PIVC insertion. So part of this solution in our situation is multidisciplinary, and specifically that's between theatre ward and cancer ward. I often get the opportunity to go to the ward to cannulate someone who nurses up there are unwilling or unable to cannulate. There's an acceptance on the ward that these procedures take a little bit of time, so I'm sure that I could work some time in to do that in that setting rather than in the theatre setting, so that way I can get some practice. And of course, also going to the cancer ward, organising something there so that because they actually have a cohort of nurses there that are doing this as daily practice, but they also have that supervisory element there too, and that will go a long way too in getting this to become every day, not just in cancer ward, but throughout the hospital as a whole. So, to start concluding all this, I guess there are two main factors to overcome to integrate these skills into everyday practice, and that was time and strategy. And while I've spoken about time, I haven't touched on strategy. Underlying all this is I'm willing to educate and push for changes in relation to integrating this aspect of patient care into daily practice. And obviously further discussion has to take place between myself or us as a cohort of nurses, between us and our managers, to highlight opportunities and to work to the betterment of our patients. I also feel there's been an effort to pay for this training, but there's not been any thought about the barriers to the implementation. And that evidence of paying for that education, they've acknowledged that there is a need, there's a backdoor acknowledgement of that, there's a need to do something. But again, like I said, no thought to implementation. And I guess that's where we come in. So those of us that have done that training can collaborate in our approach to actively seek the opportunity not only to practice the skills, but promote them to the relevant parties, so that they just become part of the everyday. And that then goes on to reduce those psychological effects of multiple attempts on the patient. So where to from here? So I've pretty much touched on all these points before, but I need to be proactive. I need to approach my managers, maybe take on a shift. They're quite open to us doing this sort of stuff, so I could take on a shift or two in the cancer ward, or even the ward for that matter, where they have a shift where cannulation is coming up. They do iron infusion days, so out of half a dozen people you might get one that might need investigation with the ultrasound and ultimately maybe an ultrasound guided cannulation. There also needs to be collaboration between us as a cohort of nurses that did this course, because we've now, I guess, had our eyes open to what is possible. we have the equipment available, we have everything there, but collaborate between ourselves to get everyone up to a certain skill level. We also need to educate. So not only do we educate our patients, but to stakeholders, I guess. So we're talking about our anaesthetists, we're talking about our haematologists, we're talking about GPs on the ward, managers. So we have to take on that education role. And further to that, we need to, and finally to that, we need to seek those education opportunities to further develop those skills.